Good evening, everyone. And I don't know if Dr. Frank Martin has joined in, but he is joined. He has. Yes, okay. So welcome to everyone who is speakers as well those who have joined through Zoom link as participants. Welcome to this webinar. The theme of the webinar is going to be anterior segment. And as you can see from the program that there are lots of eminent speakers lined in. Let me introduce my co-moderator, Dr. Jason Yan, who comes to this webinar from Hong Kong, and he is a very, very well-known researcher and has done seminal work on myopia as well as several other topics. So, Dr. Yan, you can take it from here and maybe introduce invite Dr. Frank Martin to give the opening remarks.
Thank you, Samantha, for the very kind introduction. And welcome all the colleagues from India and all over the world. And it is our great pleasure to have our joint webinar of the Asia Pacific Strabismus and Paediatric Ophthalmology Societies with Sankara Nethralaya, also MCOA. So let me introduce our president of APSPOS, Professor Frank Martin, and also our scientific secretary, Dr. Surendran. Okay, so may I now let Professor Frank Martin to give us opening remark.
Thank you very much, Jason, and thank you everyone involved in organising this symposium. We're living in very unusual times. Who would have thought a year ago that we couldn't meet face to face? The only way we could see each other around the world would be by Zoom. Yes, we're very fortunate in Australia that COVID-19 has been very well controlled. The parts of the world are still suffering and in crisis. Hopefully, one of the vaccines that have been developed will be successful and work. And by this time next year, we'll be starting to travel again and we will be able to meet face to face. The organisers have put together an outstanding program, and I'm sure that everyone will enjoy listening to the speakers. They've been carefully selected for their knowledge and outstanding ability to present. So that's all I have to say. Thank you again for organising this symposium. Thank you, Jason.
Thank you very much, Professor Martin. And also, may I also invite Dr. Surendran, who represents the Sankara Nethralaya and also MCOA, to give us the opening remark. Dr. Surendran, please. Sorry, we can't hear. Sorry, we can't hear. Can you unmute the mic?
Now can you hear?
Yes, sir. Yes, sir. Please go ahead, sir.
So good evening, I think all of you. I think this meeting was an accident because we were supposed to have the meeting at Bali, and I think because of the COVID, when it was cancelled, Professor Frank Martin, the founder, and Jason requested us to conduct the meeting from India. So this is 5 o'clock at India. Welcome to the meeting organized by Asia Pacific Strabismus and Paediatric Ophthalmology Society, Sankara Nethralaya Chennai, and also Madras City Ophthalmic Association.
With that, can we go ahead and invite first speaker of the day, Dr. John Gray. Dr. John is He's a glaucoma specialist, and he is going to talk on the place of eye track system in pediatric angle surgeries. May I request Dr. Gray to audience, may I request those of you who are joining on the YouTube, on the Zoom link, can you please mute yourself, all of you? And also, if there are any questions, please send it on the chat box. We should be able to take questions depending on the time.
Good evening, everybody, and thank you for the opportunity to present tonight and this evening. It's a great privilege to be able to share this over a distance. And so I have no disclosures. And the topic we're going to talk about tonight is primary congenital glaucoma and the evidence for new ways of evaluating angle surgery. So just to set the scene, we recall that goniotomy was first described by Barkin in 1938, and then the classic trabeculotomy went through some evolution through the 1960s, with Buran in 1960, Redmond Smith in 1960, with really a 360-degree type of a procedure at that time. Then Allen and Buran published their outcomes in 1962, and Harms and Danium modified the technique in 1970. So just to compare the advantages and disadvantages between the two procedures, for goniotomy, there's the advantages of direct visualization. So it allows precise location of the incision. You preserve the conjunctiva, and it can be repeated. The disadvantages, however, are that it's really only effective in primary congenital glaucoma. You do need a clear view. It's technically demanding in a large eye with a lens that's easy to prang. And complications include corneal endothelial angle and lens trauma. Whereas a trabeculotomy, the advantage can be performed with opaque corneas, and it's similar to the surgery of trabeculectomy, which many are familiar with. Its disadvantages are that the angle is not directly visualized, there is conjunctival disruption, it requires special equipment of the trabeculotome, and challengingly, the Slim's canal may not be found in 4 to 20% of cases, and it is possible to develop hypotony. So what's happened over time? We've now got some variations, and that's a re-emergence of the 360-degree trabeculotomy. We've had a number of studies now that show that using viscoelastic material at the time of the trabeculotomy increases the success rate. But this has really been a slow evolution in surgical approach, and this is related to the low disease incidence and really the lack of willingness to accept learning curves. It also is a way that primary congenital glaucoma is managed differently in different countries. So in Europe, the glaucoma specialist covers both the pediatric and adult services, whereas in really the USA, UK, and Australia, then it's a pediatric ophthalmologist. So, and I think that's probably similar to the case in India from discussions with colleagues. So what are the outcomes? Well, really, the outcomes for angle surgery are very good. And if we go back even to the Barkin in 1953, there was an 80% success rate. And that's really been the benchmark over the last sort of 70 years. And when we compare the goniotomy or trabeculotomy, they're still around the same sort of rate. We have one study here in 2011 from Julian De Silva, which had 30 eyes that were followed for an average of 34 years. And even at that time, there was almost a 60% success rate continuing. I'd like to present some of our outcomes from a study we published in 2015. And so we had 3 main outcomes. And really it was, the question we asked was, does age of presentation or first surgery influence outcome? And we did find that the younger the child presents at diagnosis and surgery, they had a worse visual prognosis. So the visual outcome was worse the younger they are. However, we found no evidence that the age at first operation, and we divided into 4 groups of birth within the first 4 weeks, less than 3 months, 3 to 6 months, and more than 6 months, was associated with angle surgery failure, or with an increased number of angle operations to be successful. So it didn't matter what age they presented, then their rate of success was still very good. The other interesting thing was that we looked at, as the standard in the study we followed for 23 years, the number of degrees of angle surgery needed to achieve successful glaucoma control. And we found that in almost 80% of cases undergoing primary trabeculotomy, they were controlled with just one operation, which opened 4 clock hours of angle So it's 120 degrees. And so that gives a clue as to the success rate, and that's sort of been consistent with the literature over time. The question is, do we need to do more? And that's what we'll look at in a moment. Another interesting point where we looked at was that we looked at in the time, once the children had had their angle surgery, how many more operations did they have? And we found these sort of clusters that occurred around the age of 3 and 5.5 to 6. So the first sort of 12 to 18 months, they would have their angle surgery. 75% would respond to one angle procedure, then 90% responds to 2, and there's this 10% left that needed more procedures. And once the angle was treated in that first 18 months, we then found little clusters, as we said. What's interesting is that after the age of 8, we had really hardly any operations at all in this cohort of 110 eyes. We had 8 patients required an additional operation. And this probably has something to do with the fact that by the age of 8, the angle and the outflow pathway has reached adult maturity. So it's really trying to manage these times. The other thing that we anecdotally feel with those 2 peaks around the age of 3 and age of 5.5 to 6 is that it often corresponds with the child's growth spurts at those times. And we've certainly seen in the clinic when children grow, then there seems to be an imbalance in the production of aqueous and outflow. So coming to the main component of our talk tonight is, what about a 360-degree trabeculotomy? And this was first described by Sarkisson in 2010 in a publication in APSPOS, and they used the eye-track system, and that's an illuminated microcatheter. I'd like to highlight the procedure here and go through. So it starts like any trabeculotomy, and with identification of the angle structures, looking for the demarcation from the sclera to the surgical limbus. Once we find the Slim's canal, this catheter is much finer than the Harm's trabeculotome, and we can see this it feeds quite well in here. But in this case, what I wanted to show, the first part, is the catheter's heading off away from the limbus into one of the collecting channels. So despite coming back and reorganizing it, we weren't able to get past that collecting channel. So we then started the other way and progressed round. And this time we were much more successful in passing the catheter around. It's interesting how in the large ophthalmic eye, this eye was 14.5 millimeters, that often the view is lost. And so I cut that part out of the video. And here we are coming back towards the original origin. We've managed to navigate around and avoid the collecting channels this time. And then what's interesting as we're pushing forward here, the catheter is already starting to push through the trabecular meshwork just on the first clock hours going to our left there. And now we've managed to get the catheter both ends, and by grasping gently, we've then started to pull, and you can start to see it comes from the left side of the screen as it gradually comes around, just gently pulling through and completing a 360-degree trabeculotomy. So really, what is the evidence that this actually works or changes from our long history of performing angle surgery? So I've chosen 3 recent publications here. There's the LCAID one from 2017 from Saudi Arabia, Berger and the group from Moorfields, and the Toshev group from Germany. And what we looked at here was, and it may be lost partly in your Zoom headings, but at the first 3 columns after follow-up is looking at the 360-degree trabeculotomy, and then to the right, the last 3 columns are angle surgery. So we looked at the criteria for complete success was 18 millimeters of mercury with no medications for all the studies. Qualified success was the addition of medications, and failure was if further surgery was required. So the longest study that reported here to date is a 2-year study from the LCAID, and they had a 67% success rate. They had 5 qualified. And so when you add those two together, you've really got about an 83% success rate. So that's quite consistent with the current standard that we see with trabeculotomy. When we look at they actually randomized and went to conventional angle surgery, and they've found in their cohort that complete success was about 50%, qualified success only a smaller amount, and they had failure in 50%. So their study in their hands found that the 360-degree trabeculotomy with a microcatheter was better than their conventional angle surgery, particularly considering it's one procedure. The UK group have a 1-year follow-up and just published this month, and they had 37 of 54 eyes had complete success with the illuminated microcatheter. They had 9 with qualified success. So again, this brings it up to around 83%, and they had a 17% failure rate. And when they compared it to their conventional angular surgery, which was a combination of goniotomy and trabeculotomy, 12 of those 52 eyes, they only had a 23% complete success and qualified success with another 14%. So they had failure of 63%. So I think what this study was highlighting is that the 360-degree trabeculotomy does give the 83% success rate with the one procedure, and even in the hands of Moorfields, the conventional angle surgery often required more than one procedure. If we look at the last study here, the angle surgery from the German group of Franz Grun, 1.25 or 15 months follow-up, they had 80% success rate with their group, although they had 3 lost to follow-ups. We don't understand what the success rate would be there. And qualified success in another 4, so they were claiming 100% success rate. So there certainly is evidence that it is at least as good as the conventional 120 degrees trabeculotomy or goniotomy in good hands. So then the next question is, well, what's the cost? And so the cost in Australia is 1,000 Australian dollars per illuminated cannula. And this is where the question really comes in, and we'll need to see the health economic benefit of this. But the application that was written for our hospital was that we feel that there's going to be a lower likelihood of repeat surgeries. So this cost is offset over the course of a treatment for a patient. So it's not for everyone, but it's also other challenges that occur with this is that it is not possible to completely cannulate 360 degrees in some patients. We saw in our case that we went off on a collector channel. We had to go the other way, and sometimes you can't get around all the way because of discontinuities of the Strabismus canal, and depending on the severity of the disease, how underdeveloped it is. But there certainly is a place, I think, to have one operation which then has the best chance of success to avoid future repeat angle surgeries. So that's completes the talk, and I'd like to acknowledge members of our Paediatric Glaucoma team at the Children's Hospital Westmead. So if there's time for questions, I'll be happy to take any questions.
One question which has been asked by Dr. Sudarshan Kokhar here, and he asks whether this cannula can it be reused?
In our system, it can't be, but I think there's a possibility, although it can kink quite easily. And so if you hold it too firmly with forceps, you can get a little kink, which makes it a little bit more tricky to pass. I think I saw somebody ask how long is it? It's about 15 centimeters long.
Another question which has come from the audience is, if it fails, would you do trabeculotomy or would you repeat the same procedure again?
Well, it depends. If you're unable to do the 360 degrees, then you do a trabeculotomy of what you can reach, and it depends on what amount of the angle is left. So if there's still angle that can be approached, then I'd go and do further trabeculotomy.
This is a question from me. If a lot of times while doing pediatric cataracts and you do see a little suspicious angle, so would you do a angle surgery at the time of cataract surgery as prophylaxis, or would you not?
Look, I think not. I think this is quite inflammatory, and you're going to get a high femur in nearly all the cases. And so you're adding a high femur to a cataract surgery, and I think it'd be better to treat those separately.
If there are any more, let me just see if there are more questions coming. Yeah, one more question is, what is the length of the cannula?
It's about 15 centimeters, so there's plenty of cannula.
And another question is asking, is there any problems for the beginners? Any tips for the beginners?
I think if you've performed the standard rigid harms trabeculotomies, then this is sort of an extension of that, and it's just getting used to manipulating this very fine cannula as it tends to flop around, and we tend to tape it in place with a little, with flowing in the right direction. You have to have the loop in the way you're going to direct, whether you're going to go clockwise or anti-clockwise. So there's a bit of positioning of the cannula to do that. And that sort of just comes with experience, I suspect, and getting used to sort of manipulating this very fine cannula, which is floating around on the surface of the eye, and then holding the fibre optic cable that's connected to it in a place that doesn't sort of then weigh on and try and pull the cannula out of the eye.
With that, I would like to introduce my second speaker in this glaucoma part of the session is Dr. Vijaya. She's been my colleague in the glaucoma department in my hospital for several years, and she has been my partner in crime for several years now. We have been operating together on the same day. She is a very, very fine glaucoma surgeon as well as a very good mentor. And welcome, Dr. Vijay, for this. May I ask you about your...
Thank you, Sumita. Sumita asked me to give some tips for the pediatric ophthalmologist. She suggested pediatric glaucoma, 10 things all pediatric ophthalmologists should know. So I thought about it. It's random points. It may not be linked, but definitely it is in relation to the pediatric ophthalmology and the pediatric glaucoma. So I just wanted to start off saying what is the difference, what we see grossly between primary adult and primary pediatric glaucomas. We all know that in the adult it is a silent and chronic, whereas in a child it's a very symptomatic and has a very prominent course of symptoms and signs. In adults, it's mainly degenerative, whereas in children, it is developmental. In adults, we always start the treatment for a primary glaucoma, that is open-angle glaucoma, medical management, whereas a primary congenital glaucoma, it is always surgery. That's what we recommend. Interestingly, the disc changes that happens in adults with the primary glaucoma is permanent. They are not reversible. Even though there are some claims saying that there is some amount of decrease in the cupping with good reduction of the intraocular pressure surgically, but you don't see the reversible cupping. Whereas in children, we do see reversibility of the optic disc changes, which happens mainly because of the mechanical changes with the raised intraocular pressure. The second point I want to emphasize here, which I feel is very important, is to talk the same language. That is, whenever we diagnose a patient, all of us should be doing in the same pattern. Unless we have followed a good classification system, we will not be able to do it. So this way we can share the information, publication becomes easy, and we will know what we are talking about, the failures and success are mainly for the same kind of patients we all will be treating. So CGRN, that is a Childhood Glaucoma Research Network, a decade back came together with a lot of discussion. They have come out with a good, fairly good classification system. I won't say it is 100% good, but what did they do? They categorized all the glaucomas into two groups. One is the primary glaucoma, that is what we call it as a primary childhood glaucoma, and which again subclassified. If it is glaucoma is at birth to 1 month, we call it as a neonatal onset primary congenital glaucoma. So we should not label this patient as PCG or ophthalmos and leave it. We have to be very specific. 4 years later, if the patient needs any treatment, we know what exactly is the diagnosis here, because the prognosis also differs between the groups. The neonatal onset is supposed to have worse prognosis. The second, Weber syndrome, glaucoma following cataract surgery has been grouped as a separate entity because the glaucoma that happens following the cataract surgery behaves differently and it is extremely difficult to manage. And the fourth is the glaucoma associated with acquired conditions that include steroid-induced traumatic and uveitic glaucoma. And what are the criterion to say that there is a glaucoma in the child? The intraocular pressure is recommended is more than 21. There should be definite optic changes. There should be evidence of a HAP striae or increased corneal diameter, myopic shift or increase in the axial length. In children, we should be able to reproduce visual field defect. At least 2 or more of these should be present to call it as a primary congenital glaucoma. If it is not present, and if the intraocular pressure is more than 21 millimeters of mercury, but there is at least one of these criterion present, we call that patient as a glaucoma suspect. Coming to the third point, the clinical presentation. And we usually see characteristically a triad of symptoms, that's photophobia, blepharospasm, and epiphora. Why does it happen? It happens due to the corneal changes. With the rise in the intraocular pressure, the cornea gets stretched. There will be breaks in the descemet membrane that leads to the edema, and that makes patient very symptomatic. And you see a child who avoids looking at the light and crying all the time. Even though the triad is very classical about the primary congenital glaucoma, we may not have it all three, and sometimes there can be we have to consider differential diagnosis. What are the differential diagnoses? One has to keep it in mind. Based upon symptoms, if you are looking at it, it may be conjunctivitis, it may be NLD obstruction. Very often we see this. The watering what child is having probably is related to that, or there can be keratitis or epithelial defect or intraocular inflammation. When it comes to the corneal edema or opacity, please keep it in mind. The birth trauma may be responsible for the corneal edema and the corneal injury, or it can be child, or the corneal dystrophy, even keratitis should be kept in mind. So when do we call it megalocornea? So it is good to remember that some amount of normal parameters when we are calling the megalocornea. In a neonate, it is 10 to 10.5 millimeters. By end of 1 year, it will be 11 to 12 millimeters. After 2 years, it can be 12.5 millimeters. We are talking about white to white corneal diameter horizontally. Anything beyond this indicates megalocornea. In older children, the only part stretchable will be sclera. So you will not see the characteristic corneal findings, but a progressive myopia suggests there is evidence of glaucoma. And you will also see deep antechamber may be the first sign in such children. Some special situations one has to keep it in mind. If you see any aniridia, exclude Wilms tumor. The Wilms tumor Aniridia syndrome, popularly called as a WAGR syndrome, is caused by a mutation in the 11p13 region. And this kind of a problem we rarely see in familial aniridia. It is mostly in the sporadic aniridia. In cases of Sturge-Weber syndrome, beware of the associated anomalies. The same, the hemangioma may be there in the intracranially, or it may be involving the other organs also. Especially when we are taking up the child for the surgery, we have to evaluate the the child very well to look at the other possible problems that may come up because of the hemangioma elsewhere. And in case of a congenital ectropy in UVA, exclude neurofibromatosis. This has to be kept in mind. Coming to the fifth point, when we operate on primary congenital glaucoma, what is the desired endpoint following the surgery? Ideally speaking, there should be normalization of the intraocular pressure, clearing of the cornea, reversal of the optic disc cupping, stabilization of the axial length. So this is what we call it as a optimal reversal of the primary congenital glaucoma. So to know whether we have achieved or not, we have to keep following them very closely in the OPD. We have to do a good cycloplegic refraction, give the appropriate glasses to avoid the amblyopia, and also to assess that myopia is not increasing. And we have to start the occlusion therapy very early. And majority of the times, within 1 or 2 weeks, Sumita starts occluding the a good eye and stimulates the operated eye when, as long as there is a good clearing of the cornea and the control of the intraocular pressure. And at appropriate time, patient should be referred for the corneal transplant if it is needed, if there is a dense opacity. This is one of my patients where the corneal transplant was done by my colleague Dr. Sita Lakshmi years back. Even today, the corneal graft is crystal clear because it was at appropriate time, with appropriate graft, it was taken care. So the sixth point is what I like to talk about is optimize opportunities. Most of the pediatric ophthalmologists do the surgery under general anesthesia. Detailed eye exam, especially in all high-risk patients like congenital cataract patients, please do a detailed examination on the table before you do the surgery. Since the detailed examination is not feasible in OPD, it is a must we should do a detailed examination before doing the surgery. So what are you supposed to do? Try to do a good external examination, either with the handheld slit lamp or the microscope, measure the intraocular pressure and the diffraction only for the in the follow-up period, corneal diameter measurement, anterior segment examination. I always recommend people to learn to do the Gonioscopy in children, especially following the cataract surgery. If you examine these eyes carefully, in many of the times you will see what we call it as an abnormal angle. Evaluate the optic disc, document the optic disc, do the biometry and central corneal thickness. The seventh point is the gonioscopy. So in a normal child, usually the angle is very minimally pigmented and the trabecular meshwork will be very clean. Whereas an eye with the primary congenital glaucoma, you can have one of the two types of the angle. We call it as a Samplicis type 1 and type 2. In type 1, you see a kind of a concave iris with plenty of the iris processes that bridges the angle, which we call it as a wraparound angle. In type 2, the iris will be inserted anteriorly onto the Schwalb's line and you can't see any structures beyond that. So knowing this two abnormal pictures will help you to identify the eyes at risk for the glaucoma in future. The other way of documenting will be you can use a Retcam if it is available. You can see here a beautiful picture of the sample is type 1 where there is iris processes in the angle. The eighth point is glaucoma following pediatric cataract surgery. So I would recommend do a good follow-up of all operated patients. So assuming that you have done a good detailed examination before doing the surgery under general anesthesia, especially the younger age, the glaucoma surveillance is mandatory. Evaluate periodically with standard protocols, intraocular pressure, corneal thickness, refraction, axial length, and optic disc. And any shift in the towards the myopic side suggests that there is a possibility of raised intraocular pressure and glaucoma. The characteristic symptoms of PCG may not be present here. What you see will be just the diffuse corneal haze. As I mentioned, myopic shift with increased axial length suggests glaucoma. Carefully look at the optic disc, definitely suggests cupping. Try to do the gonioscopy. If you see any of the angle anomaly like what I have shown, these eyes definitely will be higher risk to develop glaucoma in future. The ninth point will be glaucoma medication. Usually in children it is for short term, and whenever we give medication, we should teach NLD occlusion to mother so that the systemic side effects will not happen. Please remember, none of these drugs have been evaluated in children. We are using them based upon the data from the adults. And we also use post-surgery residual raised IOP medication. Most of the times it is aqueous suppressants. Please remember to avoid brimonidine in small children because it can produce CNS side effects and also fatigue and sleep inducing a drug is the brimonidine. Please remember that to avoid brimonidine in children. The next last point which I like to emphasize is have a team approach. So it may not be feasible for one person to handle the complicated situations. In India, majority of the glaucomas are taken care by the glaucoma specialist, not by the pediatric ophthalmologist. We always form a team with the pediatric ophthalmologist. We also form a team with the oncology team and also retinal team, because in those children also you can have the secondary glaucomas. So team approach is the best approach in a complicated situation. Remember that, don't hesitate to take second opinion from any of your colleagues. Thank you very much for your kind attention. Thanks again for the kind invitation.
Thank you very much, Dr. Vijaya. So there are several questions I want to ask you from the audience. The first one is, what is the normal range of IOP in neonate, infant, and a toddler, do you think? The normal range of IOP.
Yeah, the question is to me?
Yes, for you.
Yeah, I think even the CGRN has said that 21 is the cutoff for the diagnosis of glaucoma, but usually the pressure will be much lower than in adults, especially when we examine the children under anesthesia. However careful you are, the anesthetics will have an effect. So I would take maybe anything beyond 16 under anesthesia will be abnormal.
Okay. And how accurate and reliable is the eye care tonometer for checking IOP in small children?
Yeah. The eye care tonometer is a very good tool, especially in OPD, where you can check the intraocular pressure when the child is quiet. You don't need even anesthetic. So what I would suggest is any abnormal intraocular pressure, if it is more than, let's go by the CGRN classification, anything beyond 21, you have to recheck with a standard Perkins. So what we do is we try to put children in to sleep, then we measure the pressure. One other way of doing it will be tell parents not to feed child, come to the OPD and give good feed, child will fall asleep, you can complete the entire examination.
Okay. Another question is, if there is a bilateral cases, will you do surgery for one eye at a time or both eye at the same time?
You can do the both eyes same time with the different scrubs, treating two eye surgery as a two separate surgeries.
Okay.
So to avoid the repeat anesthesias, people do advocate both eyes same sitting. In our hospital policy is, if there is a risk for the repeat anesthesia, we take a special consent and do the both eyes together. Otherwise, we tend to do with a 1 week gap.
Thank you. So another question is, for pediatric cataract surgery, do you recommend to do gonioscopy for them?
Especially for the small eyes and eyes where you cannot put the intraocular lens, the microcorneas and by birth congenital cataracts, These are the eyes at a high risk, and the cataract may be part of the problem child is having. Probably child may be having some amount of angle dysgenesis also. So it is good to do the gonioscopy and document the possible changes. So if they have any of the dysgenesis which I have shown, these eyes definitely will need more careful follow.
Okay, another question is how much reversal of the optic disc changes would you see on average after the surgery for if it is successful?
Yeah, I think if it is when the pressure becomes normal, the cornea clears well. On the table, we would have documented even 0.6, 0.8. In a week to 10 days time, you see the reversal happening. And when they come back to us in 6 weeks time, recently also I had a case where the cup disc.
And also Professor John Grigg has made Professor John Grigg has made a comment on the critical message highlighting the need to implement the CGRN classification system in the practice and reporting the outcomes. Thank you, Professor Grigg. And another question is the medical line of treatment. What do you suggest?
We tend to treat most of our children before surgery if there is a need to give the drops. A selective beta blocker like bitoxolol. We try to avoid the non-selective one like timolol because when we give the anesthesia, there can be issues. And dorazolamide, that is aqueous suppressant, CA inhibitor is another drug. These are the most popular drugs in our practice. And we don't know whether the prostaglandins will be effective, whether the uveitis outflow system in children is well developed or not. We don't have evidence to prove or disprove.
Thank you very much. Okay, thank you. So because of time, then let's proceed to the third speaker. So may I now invite Professor James Elder to share about the topic on the pediatric uveitis. Professor Elder, please.
Thank you for inviting me. Can you see my screen?
Yes.
Yes, we can see.
Yeah. Okay. I'm going to give a quick run through pediatric uveitis. Going to talk briefly about classification and nomenclature, etiology, pathogenesis, epidemiology, and management principles. And I'm going to illustrate that with 3 different situations: endogenous, JIA associated, and retinoblastoma as a mimic. We should probably all be using the standardization of uveitis nomenclature now. Their classification is well known to everyone and is an anatomical classification. The SUN system also has descriptors which are very useful, describing the onset, duration, and course of the disease. And as you'll be well aware, grading for anterior chamber inflammation, both in terms of cells and flare. Importantly, also, they defined activity, which is very useful when considering cases in what's a significant improvement or worsening of the disease, when it's in remission and when it's inactive, and all of these things we should use regularly. You can classify uveitis etiologically, as you're well aware, infectious and non-infectious. It is important to remember masquerade syndromes, and I'll particularly talk about retinoblastoma, but leukemia and xanthogranuloma and others can present as masquerades of uveitis. With the infectious, any infectious agent can cause it. It can be acute or chronic. What you actually see in the eye may vary with the degree of immune competence of the host. Non-infectious is universally thought to be immune-mediated and has a frequent association with systemic disease. Epidemiology is really very variable. It depends on where you look. There are relatively few population studies. One from Finland suggests 4 cases of pediatric uveitis for 100,000 people. If you look in general versus tertiary practices, you'll see a different spectrum of disease. And the same applies if you look at single centres. You often see various biases in that. The principles are accurate diagnosis, treating the cause where it's possible, obviously reducing inflammation, but at the same time minimising any iatrogenic damage. And as many of these diseases are chronic, it's necessary to monitor and titrate treatment appropriately and manage any complications as they arise. And it frequently requires a multidisciplinary approach. When considering endogenous endophthalmitis, this is spread hematogenously to the eye. There's some studies that suggest that this is relatively infrequent within patients with bacteremia, but presumably these patients were being treated. Fungal endogenous endophthalmitis occurs. I personally particularly see this in immunocompromised hosts. And the presentation can be quite variable from acute to insidious. As many of the audience here is from India, you probably see endophthalmitis occurring in children with partially treated infections presenting from the community. An accurate microbiological diagnosis is important, and that involves systemic and ocular assessment. As well as doing blood and urine cultures, it's necessary sometimes to consider other sites like IV cannula and major wounds. The investigations obviously are microscopy and staining, culture, and increasingly PCR technologies, particularly with viruses. The treatment needs to be aggressive with appropriate systemic and intravitreal treatment. Often multiple agents will be required at the start if you're unsure as to exactly what the etiology is. Vitrectomy may be important both from a diagnostic point of view and from a therapeutic point of view. Steroids are sometimes used. The visual outcome for endogenous endophthalmitis is often poor. Some organisms are worse than others, particularly Strabismus, and the visual outcome and indeed loss of eye can be quite problems. The non-infectious uveitis that I want to consider quickly is that seen with juvenile arthritis. The synechiae and band keratopathy and cystoid macular edema will be familiar to all of you who look after these patients. The clinical features are such that it is often asymptomatic. It's a chronic disorder. It can occur at any stage during the course of the arthritis, before or well into it. Most commonly, it presents within 5 years of diagnosis, and its incidence does vary in different population groups around the world. The pathogenesis is it's considered to be immune disorder. There are many reasons to think of that. The genetics is not at all simple, though familial cases are described. Complications are a major problem of this because it's a chronic uveitis, and these can involve the cornea, lens, glaucoma, and posterior segment, as you all well know. The management can be thought of in 3 parts. The first is surveillance of children who have arthritis to detect uveitis when it occurs. The second is the management of the uveitis, and the third part is the management of complications that may ensue. The Children's Hospital in Melbourne, we have a fairly simple thing, which is a surveillance schedule, which is partly age-based, and it's also based on whether the child is ANA positive. If the child is ANA negative or has systemic type JIA, the surveillance need can be less frequent. These children are often difficult to manage, partly because they're young. We tend to manage them in a tertiary centre and do this in conjunction with our rheumatology colleagues. And they need aggressive treatment to avoid complications. Steroids remain the mainstay of treatment. And if these fail, escalating use of disease-modifying agents, the usual progression that we follow is steroids, then methotrexate if there's failure, and biological. Generally, unless there's sight-threatening complications occurring, you persist with one treatment for 3 months before progressing. Another reason to progress to disease-modifying agents is if you require ongoing high doses of steroid because of the risk of steroid-induced damage. The evidence is quite good. There's at least 60% of cases show a good response to steroids, but side effects are common, as you'll be well aware, with chronic use of these agents. There are no randomized trials that show that methotrexate works, though there's a recent systematic review that shows or suggests that in about 70% of cases when this is added, there is a reduction in the uveitis. The biologicals, there is a number of randomized trials. There are at least 2 trials for adalimumab and methotrexate, which showed better control of uveitis with fewer relapses and reduced steroid use. There are a number of adverse effects, most of which are relatively minor. One of the big uncertainties here as to how long this needs to be continued, and there are discontinuation trials being undertaken now. Some of the other newer agents, one is tocilizumab and methotrexate used after relapse on an anti-tumor necrosis factor. Treatment with methotrexate has shown some improvement, and so this can be considered in some cases. I'm not going to go through these slides in any detail as they're quite complex, but it's a good idea to have a protocol which you follow when you're planning to escalate treatment. And as I said, generally there's 3 months of one treatment and progress. And then there are protocols being developed for discontinuation of treatment, but you need to have good control for 6 to 12 months before considering that. The surgery is mainly, in my experience, for cataract, glaucoma and band keratopathy. You need to be very cautious about doing this as the uveitis is not adequately controlled, and it's important to use high-dose steroids perioperatively to control any flare and inflammation. With uveitic cataracts, we very seldom put an implant in unless the eye's been very quiet for an extended period of time. All children have posterior capsulotomies and anterior vitrectomies if possible. The steroids that we use depend really on the degree of activity, but we do at times for children that have had recent active disease admit them for pulsed methylprednisolone at the time of surgery, as well as using intravitreal and topical. Glaucoma surgery, decision-making here has to be made carefully. There's a significant risk of postoperative hypotony. These children often have borderline ciliary function, even though they have raised ocular pressure. I have a personal preference for using a tube over trabeculotomy. Perioperative steroids are similar to those used in cataract surgery. Subtenon's mitomycin is used. I use a barbell tube with a small plate, generally, with a tie around the tube and an intraluminal suture. The intraluminal suture does not always need to be removed. In summary, the management of JIA-associated uveitis is complex, complications are common, and a multidisciplinary team is, vital rather than very important. Retinoblastoma as a masquerade, it really just needs to be aware that not everything that presents as uveitis is uveitis. Diffuse anterior retinoblastomas can present, and they can have a number of features such as iris neovascularization, a pseudohypopion, seeds on the cornea or lens, occasionally nodules, secondary pressure problems, and hyphema. Posterior segment, there's often not a discrete mass. It's an ill-defined subretinal tumour frequently, but with vitreous seeds and vitreous hemorrhage. This is a child I saw many years ago who in the superior part of the pupil there you can see a white shadow which was extensive vitreous changes. This child here, you can see a dusting of cells on the lens capsule and also in the posterior segment vitreous deposits. These children often have quite advanced disease at presentation and are frequently treated with enucleation, unfortunately. In summary, paediatric uveitis, as we all know, has a very wide range of clinical features. It's frequently associated with systemic disease. Accurate assessment and diagnosis is vital. It is necessary to adjust treatment to severity and disease progression, and you need to have a formal protocol for that, particularly with situations like JIA-associated uveitis. And there may be significant complications that are either secondary to the disease process itself or to treatment. Often a multidisciplinary team is needed. Thank you.
Thank you, Dr. Elder. That was a very illuminating talk. One question which has come from the audience is, which biologic is safer? Is it interleukin inhibitors or TNF alpha antagonists?
The main ones that are used around the world, I think, are the anti-tumor necrosis factors. So adalimumab, or Humira, it's called in Australia. That's the most common, biologic disease-modifying agent that we use. Etanercept is not terribly useful for uveitis. Infliximab does have an effect on uveitis. Its delivery is a bit more complicated because it's given by infusion, and it has significantly higher systemic side effects in that anaphylactic reactions are much more common with that. And then the other agents that we use is tocilizumab, which is an interleukin antibody.
There are two questions on IULs in these children. You said that probably JIA still remains a kind of relative contraindication for putting IUL despite several years and work, but is there any other condition where you would consider putting intraocular lens? And I'm sure it has to be in the bag, because the question is whether you should put it in the bag or leave them ophakic. So yeah. I think there is no role for sulcus fixated IULs in uveitis eyes.
No. The situation that we have in our particular population cohort is we see relatively few children who have cataracts that have completely quiet eyes for extended periods of time. And that's why we're very reluctant. We've had a number of patients that have had very problematic flares of their inflammation despite intravitreal steroids and perioperative steroids. So we're just very cautious. We do have the occasional older child in whom we're not in any rush to do the cataract, that we've followed them for 6 or 12 months with zero activity, and then we've been prepared to implant them. But we're just very cautious, as it's an invitation to a lot more problems.
Another question is how to differentiate diffusely infiltrating retinoblastoma from endogenous endophthalmitis.
Usually the diffuse anterior retinoblastoma will not be particularly inflamed, and the cells, I guess one of the things is in slit lamp, you often see clumps of cells, and most children who have endogenous endophthalmitis have a more acutely inflamed eye. The cells are all uniform size like other uveitis, so they're all relatively uniform, whereas with retinoblastoma, they're not. The other thing is the vitreous changes. In my limited experience with it, I've only seen 2 or 3 cases of diffuse anterior, but they often have clumps or little fronds of vitreous disease. It's possible that UBM may be helpful because you may show thickening around the ciliary body and the anterior retina, which may be helpful to distinguish it with the retinal tumour. I'm sorry, I can't hear you. You're muted.
Another question is, how long would you keep them on steroids after cataract surgery, post IOL?
The high dose steroids, it's dependent on how much inflammation you see. So usually we would use 5 days of systemic steroid, and then reduce depending on what inflammation you see. I don't think it's easy to be prescriptive about how long the steroids are needed for. The other thing with cataract surgery is If they've been quiet, but you've required methotrexate or a biologic, you clearly don't change that immediately prior to any cataract surgery. You continue their systemic immunosuppression around the perioperative for cataract surgery. So the steroids may continue for many months afterwards.
Last question for Dr. Elder. Have you seen a child with sarcoidosis and uveitis?
Personally, no, I haven't. It must be an incredibly unusual diagnosis in our population group. We've thought about it on a number of occasions, but I don't believe we've ever had a formal diagnosis of sarcoidosis.
Apology for all the technical problem. It is very disturbing and interrupted, and I hope it will not be happening again. And so without further ado, let's move on. We are very thankful to Professor Elder and also Professor John Grid to join us for the excellent talk, and also Dr. Vayaja. So we are now moving to the fourth speaker, to Dr. Mina, to share all about pediatric keratoconus.
Is it good to go?
Yes.
Hi, everybody, and thanks for having me over. Very nice to be here. After learning a little bit of glaucoma and uvea, it's time to move on to some cornea. So I've been asked to speak about pediatric keratoconus. As we all know, pediatric keratoconus is a burning issue. It's something like an endemic issue happening now. It's a bilateral asymmetrical disease. It's something like a degenerative disease. It starts early in life. It stands for kerato in Greek, which stands for horn, and conus, which means cone. So practically, you're dealing with a deformed cornea. It is one of the most commonest ectatic disorders of the cornea, the others being pellucid marginal degeneration and keratoglobus, which are usually not that rare. It was described as early as 1854. So when it presents to us, these are children or very young adolescent children present to us with unstable refraction. They go to clinics, each and every clinic, and try to get a better glasses for themselves. They have an asymmetrical visual acuity, meaning one eye could be seeing well and the other eye could be having a subnormal vision. Very intelligent children will also tell you that they are seeing doubling if it's unilateral keratoconus. Much earlier than the loss of Snellen acuity could be the loss of contrast sensitivity. Of course, these children, they are very young, cannot be tested for these. Very unfortunately, some of these patients present to our clinics with pain and photophobia with acute onset, and parents looking very, very apprehensive because of the presence of eye drops, which occurs in advanced presentation of these diseases. It's very important that you ask for history of frequent rubbing and blinking in these children, because allergy is one of the most common associated factors in keratoconus. Why are we discussing this today? We are discussing this today because we are dealing with a progressive disorder. Your patient comes to you with myopic and irregular astigmatism, for which it is very difficult to give glasses. It starts very early because the youngest child in literature which we have reported keratoconus is as young as 4 years. And this thinning is visually impairing, as I told you, is progressive. In screening, in those populations where screening has been done, 9% of advanced myopic patients have had reported to have keratoconus. And it's very unfortunate that some of these patients have been misdiagnosed as having meridianal amblyopia simply because the keratoconus was undetected. Few countries have also recommended that keratoconus should be a recommended screening program in their visual acuity screening. When you look at the epidemiology and prevalence, you will see far most that the Middle East and Southeast Asian countries are far more published these disorders. Probably this is a disease of Asians and the Black population. It also depends on these publications whether what method of screening tool they have used. The finer the tool, the more increase in prevalence of these diseases. Generally, there's a male preponderance, and most of the studies will report that if it is unilateral, and 50% would have progressed to bilateral at the end of the testing methods. So, among Asians and Caucasians, in the Caucasian study, when they looked at their subpopulations, most of the patients who had keratoconus in their studies were Rhizotocine, again, is nothing but an internal reflection which occurs because of when you illuminate the temporal side, the nasal limbus looks very illuminated. The other slit lamp biomicroscopic signs, which are fairly easy to find, are prominent corneal nerves, and also, as you've seen here, an apical protrusion of the cornea, which will correspond, if you do an imaging study, which will correspond to the highest part of the cone. As I already said, then there is a Fleischer ring here, which is nothing but because of the elevation of the cone, there's tear film displacement here, and there is thinning at this level, and there is deposition of hemosiderin, and this will be outlining the cone, which helps the surgeons also to define the limit of your cone while doing the surgery. So you generally like to involve this Fleischer's ring when you do keratoplasty, because this will mean that the cone is encompassing up to this L extent. Vogt striae is also seen when it is advanced keratoconus. As you can see, these are vertical lines which are seen in the deep stroma, and they tend to disappear when you simply put some pressure on the upper lid. It only means that when there is a redistribution of the pressure over the rest of the cornea, they disappear. So they occur in fairly advanced cases. I've already mentioned that prominent corneal nerves, because there is corneal thinning, these corneal nerves appear fairly more demarcated, and there is also anterior scarring, not only in contact lens wearers, but also in non-contact lens wearers. There is subepithelial scarrings, and this coincides with the area of maximal ectasia. And as I already said, unfortunately, some of them come to us in the advanced stages suddenly with an acute hydrops. Some of them can be unilateral also, and that's why they tend to miss it. And this is nothing but because of the advanced thinning, there is a break in the Descemet's membrane, and the aqueous simply seeps into the stroma, and up to the level of epithelium, there is so much edema that it causes so much of photophobia to these patients. You need to only reassure these parents who are very, very apprehensive. The other method of treating them will be to give hypertonic saline, some lubricants, and cycloplegic agents. We also recommend surgery when it is very advanced thickening to reduce the time of healing. Now, nevertheless, you have to see the other signs of allergy, like giant papillae. Flip the upper lid, do not forget, and look for signs of limbal papillae. You will see these patients in the early stages without these slit lamp features will have other ophthalmoscopic findings. And this is really very important, because if your patient is not improving to 6/6, you can look to the chart and see if there has been a scissoring reflex. In the scissoring reflex, the central reflex will move in the opposite direction, and the peripheral, which will be more hypermetropic, will move in the same direction. And also an oil droplet reflex has been demonstrated. We rarely do this with the direct ophthalmoscopy. The keratometry, when these patients are able to cooperate for keratometry, you will see doubling of the Myers, and you simply cannot align these Myers even if the astigmatism is as low as 1 diopter. And with this, they have classified the keratoconus as mild, moderate, and severe using the keratometry. The investigations that we'll need when there is a scope of doing more investigations, or when you are able to send the patients over to the cornea clinic, would be to confirm the diagnosis or screen these patients with topography, tomography, OCT, and pachymetry. It's important to look at the topography and know that in normal eyes, there is a fairly equal distribution of the powers over the entire range of the cornea. There is a bow tie asymmetry in normal corneas, even with high astigmatism. In keratoconus, it's necessary to know that there is inferior steepening, which is the earliest sign. Remember that keratoconus most commonly starts at the inferior quadrant of the cornea, and it always reflects as a mirror image to the opposite eye, which is known as enantiomorphism. And with the help of topography, we are able to screen these patients to look for its progression to some extent. You can classify them as mild, moderate, and severe. Mild will be that they are involving 1 quadrant of the cornea, and moderate will be just about lying above the 180-degree axis. And in severe keratoconus, you will see that the high dioptric values are involving near total part of the cornea. So these are some of the suspicion indices which help us to know that this patient could have keratoconus. Nevertheless, topography, it cannot actually be 100% specific. But any keratometry value which is more than 48 diopters, or if there is an irregular astigmatism as described by topography values known as skewed radial axis of more than 21 degrees, or if there is a superior inferior difference of 1.4 diopters, you should be able to try to do more study and look to rule out keratoconus. Many keratoconus indices are available in the software that you would have in your topographers. And simply knowing that keratoconus is not only a problem of the anterior corneal curvature, but also a problem of the posterior corneal curvatures, tomography has come to play an important role in finding the earliest form of keratoconus. It uses an elevation map. It uses something known as a reference plane, and any plane which lies above and below is given in colored coded maps. Anything which is lying higher than the color-coded maps is in positive, which will be in red, and something which is plain, which is flatter, will be in blue color. Along with the tomography, which is most commonly the Scheimpflug devices, the pentacam device, Oculus pentacam, which we use, they also give you what is known as enhanced bad display. And recently, we have also started using the Bellin ABCD grading system. These two have helped us become more specific in ruling out keratoconus from other features which could resemble keratoconus, like recent use of contact lens, like contact lens warpage. So this is how the quad map of a pentacam looks. It gives us the front surface, it gives us the back elevation and the front elevation, and most importantly, you can also see the pachymetry which corresponds to the highest elevation on the same map. We have now evolved from Placido-based system to keratoscope, but whatever it is, you need to have a baseline evaluation. You need to know which keratometry you used, and you'll have to classify the grade of keratoconus either as mild, moderate, and severe. We have the Ansler-Krumish criteria, or we have the tomography indices giving us the posterior elevation maps. When do you suspect keratoconus? So when you see a patient with frequent itching and rubbing who has a keratometry value of more than 48 diopters with a high irregular astigmatism, which is not orthogonal, patient is 6'6" but is unhappy with his glasses, and he keeps saying that when he presses his eyeball, he sees better. And there's a family history of keratoconus, and most commonly, many times we are able to pick up these patients when they report to the refractive surgery clinic asking for refractive surgery. The tools for screening for these patients are far more sensitive in the refractive surgery clinic. So the global consensus for ectasia and keratoconus defined in 2015, but that whenever there is steepening of the anterior corneal surface, steepening of the posterior corneal surface, or when there is thinning, when you in the central part of the cornea, you have to define this as keratoconus. What it simply means is that most of these studies which have used this screening tool have used the Kmax, which is the value of the maximum keratometry value on the pentacam of more than 1 diopter, as one of the important means of saying that there is a progression of the disease. How soon would you say progression is not been very clearly defined, but you would see these patients every 3 to 6 months. Look at the management of the keratoconus when we see these patients. Most importantly, you're looking at the progression of the progressive disease. So it's important to control the risk factors. So you need to control the allergy in these patients, which could be the underlying risk, one of the underlying problems. So we have another speaker in the same session who's going to talk about allergy. We start off with topical mast cell stabilizers. We would also recommend very pulse dose of low dose steroids, and very rarely steroid sparing agents. You need to also know that you have to monitor these patients once you start these disease to know whether there is progression. You have to inform the caretakers and the parents about the disease. Do not go into the realm of doing a keratometry or a Scheimpflug imaging for all myopic astigmatism. Many times we see parents who are very, very apprehensive because the parents have been told that the child has keratoconus simply because he has astigmatism. You need to diagnose it and only then confirm the diagnosis and tell the parents. And once it's diagnosed that there has been a progression, we have what is known as the corneal collagen cross-linking. So in the mild forms of so we have already described that based on the dioptric values, we have mild, moderate, and severe. For lack of evidence of being a very clear of lack of my own experience, I would not be talking about the role of intracorneal ring segments in moderate disease or the role of Bowman's layer transplantation. But however, let's go into some of the other modes of treatment. Spectacles stands for early keratoconus. Yes, this is what you would want to give when it is non-progressive and you're able to follow it very closely, especially also for unilateral keratoconus. But also always keep in mind and tell the parents that the very frequent change in glasses, you would have to step up the use, provide them with the treatment of collagen cross-linking or need to give contact lenses. The types of contact lens based on the grades of the keratoconus are soft toric contact lenses, corneal RGP lenses, including the rose-scale lenses, the piggyback lenses, the hybrid contact lens, corneoscleral lenses, and the scleral lenses. The most advantageous, however, are the Boston scleral contact lenses because they can vault over the entire portion of the anterior surface of the globe and correct any amount of irregular astigmatism. It also helps in those keratoconus patients who have severe ocular surface disease. Now we will go into corneal collagen cross-linking. We have in 1998 given a very good tool for now stopping the progression of keratoconus by the first report by Sporel and Willensack describing a photosensitizer and a photosensitizing agent which causes biomechanical stiffening of the cornea. This uses UV radiation with the help of riboflavin, which gets photosensitized by this UVA, causes the collagen fibrils to become more cross-linked because of oxidation, which occurs because of this underlying process. We mostly use the Dresden protocol. When you are dealing with pediatric age group patients, it has to be done under very sterile conditions, and some of these patients are able to cooperate. We do it under topical anesthesia, and some of them will need gentle anesthesia, especially if these patients have Down syndrome. Having the parents around when the patient is undergoing the procedure simply makes it a little easier. We do not recommend doing both eyes at the same sitting. However, if the patient is at high risk for general anesthesia, we would do both eyes. We now also have progressed into using an accelerated protocol, which has reduced the time from 30 minutes to 10 minutes. We have published our report of more than 377 eyes, and we have noted that there has been not only a stabilization of the keratoconus at 2 years, but there has been a minimal good refractive outcome also of these patients. However, our studies also recommends that beyond 4 years, there has been some patients that could progress. So it's important that if you do collagen cross-linking or send the patient for collagen cross-linking, you need to keep the patient under a very close follow-up. The general recommendation from our study was we included the Kmax, which increased between 2 visits of 1.5 diopters, increase in the cylinder value of more than 1.5 diopters or the topographic cylinder, or reduction in the thinnest pachymetry of less than 15 microns. So it's important to monitor progression and just not give the leave the patient alone. Some of them can progress, and although we do not know the protocol for re-CXL, it's important to counsel them that some of the cross-linking could simply not be effective. It's also important to tell the parents that there is a remodeling which keeps occurring and new collagen keeps coming back into the cornea, and there could be progression. However, majority of the studies have shown that there has been good stabilization. Continue to treat the allergic disease and tell the patient for recommend contact lens. But always look for the other eye disease, what degree it is, and whether they also need collagen cross-linking. Look out for hydrox and limbal stem cell deficiency. What happens when contact lens fails either after stabilization or when there is no progression of the disease? When you have used the maximum lens possible for the patient, or the patient is simply not going to use any more contact lenses. So it is time for indicating the parents for keratoplasty, especially if there is severe apical scarring after contact lens use, or simply because it's very ectatic, or if it is post-hydrox scarring, which the contact lens again would not give you the best corrected visual acuity of more than 6/9 or 6/7.5. It's very important to know that these patients have to be under a close follow-up and need to be told for frequent reviews. So we have been fortunate to learn deep anterior lamellar keratoplasty, which enables us to remove only the anterior portion of the cornea, leaving the patient's own endothelium, by which we are having an extraocular procedure, and we have avoided endothelial rejection. And we have also been able to use those quality corneas which have poor endothelium. Who wouldn't benefit from corneal transplants are those patients who have acute eye drops. At the time of acute eye drops, it's only necessary. We sometimes give intracameral air and decompress the fluid pockets. And those patients who have advanced to severe limbal stem cell deficiency with severe allergy, they would need other forms of limbal stem cell replacement. So my take-home message will be: treat the underlying disease vigorously. Do not rub the eye. So there is a concept that there is no rub, no cone. So Damien Gatinel has also has advocated that you can advise these patients and parents that if they have this intense itching, that they could rub on the bony surface on the orbit to reduce the sensation. We do not know the re-CXL protocol as of now, but the Sienna CXL study had showed that even after 10 years, there has been a progression of these patients, especially if they were less than 15 years. So have a very close follow-up to have a frequent change of contact lenses or recommend keratoplasty in these patients. And always look at the other eye, whether they also need cross-linking if there has been a progression. And these are my recommended reading. Thank you so much for allowing me to be a part of this meeting.
So basically what I'm going to be talking about is pediatric versus geriatrics now. And you told me specifically to talk about the kids who are less than 2 years. So let's talk about the infants only. So when you see this chart here in front of you, what you notice is that one is a group in which you do a surgery and the patient has maybe 40 years more to go ahead. Whereas on the other hand, this kid is too small, and maybe 80 to 90 years to go future. So whatever you do for him should be done in a way that it does not harm his vision and his potential to see 20/20 in future. So what are the tips we can give to people so that when they start to do the surgery, it's easier for them to get into the mode of doing pediatric cataracts? Most of these guys are already doing adult cataracts, so I'll just keep comparing them during the entire procedure, the talk. So the tips for the less than 2 years is, I think in the adults, you're doing topical surgery, you can ask the patient to shift your head, move the eye, you can move the head, you can do whatever you want to do with the patient on the table. Whereas in the children, once the child is under intubated, you are not supposed to shift his position of the head. If you shift the position of the head, the LMA might come out and there could be a risk to the life. So basically what technique we do is, we actually, when we try to put a ring under the head, so this child is already under, the ring goes under the neck. The moment the ring goes under the neck, it tends to flex a bit. So if the neck is flexed, the position of the eye will not be parallel to the microscope, which is what you want to see up here, which is shown in the picture. So this is a very simple thing. You use a band, made out of the bandage. You give a support to the shoulder and bring it to a position where you can actually see the head going straight. And that's the time when you should put the cover on the eyes, not before that. So all the beginners who are doing it, if you do it later on, if you shift the patient, the LMA might slip out and there could be a problem to the patient. Second thing, you need to have a speculums of all the size. You have to have the smaller speculum, the bigger speculum, and the intermediate speculums. And these are the rings which you can use. So if you have a bigger ring, you can keep putting the wads on that and try to make smaller rings. So you can use these small rubber rings and put cotton pads around it, and you can make the size. So I have over 10 of these ones. For the videos thing, I'm showing just the 3 of them, but you can have all of them depending on the size of the patient you're getting. Okay, then comes the second tips. I think the management of anterior and posterior capsule are the most important one, because if your anterior posterior capsules are good, your lens can go into the bag and stay good. Lens in the bag is the one which is not going to rub against the posterior part of the
Dr. Khokar, sorry to interrupt, but you have 10 minutes because it's my time out after that. So please, can you expedite it? so
Yeah,
that we finish it.
Yeah, it's okay. So I know we are the domestic players, so I can understand. Yeah, thank you. So what we need to do is these are more elastic now. So Trifon Blue actually helps in a big way, because when you put a Trifon Blue, it's like a cross linkage of the anterior capsule. So anterior capsule becomes more manageable if you put Trifon Blue in these ones, and the size is important. So when you want to put the Trifon Blue, the trick is that you put a dash of 1 in 10,000 and 1 lakh Edry, and once the pupil opens up, even if you see a good glow, I'll always recommend for the beginners to put some Trifon Blue, which is 0.06%. And when you're taking out the Trifon Blue, try to put it under the bubble so you don't have the cornea getting stained, and you take it out from all the openings so the openings are marked. So whenever you want to put any instrument, you won't be damaging the epithelium or the endothelium. Okay. Then the trick is to get a 5 millimeter rhexis anterior one, so that the lens stays behind the rhexis whenever, even if it gets fibrosed. So what you need to do is you can use the old arcade refined markers. You can put it on the cornea to give you the mark, or you can use a silicone ring. If you're Tessigan and you're staying in Belgium, you can afford one. I have a microscope in which there's a shadow of the 5 millimeter comes onto my cornea, so I can actually do that one. So what you need to have a simple Utrata forceps. So if you're using a bigger forceps, bigger incision, you need a viscoelastic, which is having high molecular weight. And if you're using intravitreal forceps, you can get away with the methyl cellulose alone. So this is what you have to do. So first thing is, this is the anterior dome, anterior capsule, that's the posterior capsule. The trick is the anterior capsule has to be flattened as much as possible with the viscoelastic on the top. And when you're doing the posterior capsule, please do not overfill, because then the posterior capsule will go further away. So once I've done that, I take away all the fluid from the eye, and I don't have any duality in the chamber. So I give a nick and come from the side. Once I give a side nick, for all the beginners who are starting, they can go ahead and make an incision of 2.2 and use a Utrata forceps. Why? Because they're used to using this forceps. So when you go all around holding the eye, ensure that you hold the eye in, so that your control stays better. And if you're an adult, you're holding it for 5 to 6 times. Here you have to hold it for maybe 2 extra times. So every 2 clock hours, you can change your grip. And you see this is the central 5 millimeter zone, and we got a rhexis which is going all around it. And Utrata works wonderful. Now, this is a rhexis I'm doing with a longer forceps, intravitreal, because this patient was not having methyl cellulose. We are doing it under methyl cellulose. So what you need to do is the incision size has to be small. It's a 1.2 millimeter MVR entry, both sides. And I make 3 entries, and I can keep changing my hand in case I am not able to get the rhexis of the desired size. Now you see, since I'm holding it from the far away, my fulcrum and my leverage is not as good. You see, you can't see my right hand anywhere. So I'm holding it from a further away. So it's as if I'm using a long forceps, like you eating your noodles with your chopsticks rather than a fork. All right, but with a little practice, you can actually get away with that. So if you have a good viscoelastic, you can use a Utrata forceps, or in case there's a economy drive and you don't have methyl cellulose, you have only methyl cellulose, you can make smaller incision and get away with the longer forceps. But this is what I wanted to tell you. You can eat the chopsticks, the noodles with the fork, or the chopsticks, both can work well. Doing a bimanual is very important in these ones, because you have to use two openings of 1.2, ensuring that the openings and the diameter of your IA and these instruments, they go hand in hand. They should not be too tight. It should not be too loose to cause leaky wounds, so that your fluid comes out. And see, once I've taken away all the cortex from the left side, I'll just change the hands and go to the other side. You can use a 20, 23 or 26G, whatever suits you. Ensure that this instrument and the incisions, they go hand in hand. There should not be any bias there. Now you see, moment I take out my instruments, there'll be a little collapse of the chamber. Now you see the pupil is coming down. Now this is what happened in the pediatric eye. Now that's quite a typical, because sclerogity is low. So this is what happens. Then you change over your hands, go to the other side, and you take away the cortex from the other side also. So bimanual works wonderfully well in pediatric age group. And that's what I think everybody has to have this one. I mean, there's no shortcut on that. Now coming to the posterior capsule rhexis, which I mentioned when I was showing earlier, you see the picture up there. Now posterior capsule rhexis, you put the viscoelastic in the anterior chamber, but not into the bag. In fact, the bag has to be underfilled so that the posterior capsule is actually tenting anterior. It's something like a mini curvature of the anterior capsule rather than a posterior capsule. If you fill it up fully, it'll go away and you'll have a problem in cutting it. And if you give a nick and there's a viscoelastic in the bag, it'll actually push the capsule backwards and open up further. So your exercise might not be under control. Now you see here, I'm using a longer forceps, but I'm more comfortable here because my volume of the lens has already been lost. So all these 4.5 millimeters gone. I have more space to work. I've got a viscoelastic in the front. and I can easily go around. And you see the rectus posterior is not running away because it's underfilled. The moment you overfill it and it's taut, pushing posteriorly, it will always run out for control. So that's a technique, I think, trick for everybody who is starting this. I don't use dye for the posterior one because it makes it more brittle and it will break wherever I'm holding it. Then coming to the vitrectomy I think is a must in these patients because you're putting the adult size IOL in a smaller eye. So when you do a vitrectomy and cut the vitreous, you get more volume and the lens can be put into the bag. And it avoids the VO formation, pupillary capture of the pupil lens coming anterior reduces, and the secondary glaucoma also goes down to some extent. These are my setups. Now, how do you do a vitrectomy? Is you just go ahead with the, I'm using a Centurion machine and my cut rate is 4,000 in this one. So I can go to 4,000 all the way. So that's pretty good cut for this machine. And when I'm cutting, the end rate is the shape of the posterior axis should be the same, which I created. And you see now the fluid has gone into the vitreous and hydrated the vitreous and it's trying to come out. You see there's a distortion of the shape of the posterior capsule. Now, once I cut it and it goes back to the same position, that's the end point for it. I still have about 2.5 minutes, so I think I'll rush through this. Just, Sumita, just raise your finger when I got 1 minute left, please, right? Because I don't want to waste time there. Okay, so in case you're not able to see the vitreous, it's like a ghost in the room. So what you do is you just put a white sheet on the ghost and the ghost becomes visible. So similarly, you can use triamcinolone here. And once you put triamcinolone, you can see the vitreous coming into your view. You can see it now. And you can start cutting it and get away with that. But once you're using the triamcinolone, be careful that you might have a spike of the pressure on the first or second day. So be a little careful about that. Okay, now coming to the IOL. I think in most of these patients, you're putting IOLs. So two things are important, insertion technique and the calculation of the power. I think which are very important in pediatric age group. Now, how do you put the lens is very simple. You have to inflate the bag now and the lens has to go into the bag. Now, in this one, we're not using a wound-assisted surgery like in adults, in which the cocoon can go in and open into the bag with the posterior capsule intact. So you make an incision bigger, let the cartridge of the tip go inside. So I make a 2.75 incision for my 2.2 lens. And the lens goes in. And the moment the leading haptic has gone in, I push the trailing haptic down. So my leading haptic goes upwards. It's something like a plane which is about to land. And once it's landing, the nose should not dip down into the vitreous. It should not come out of the bag. It should come smooth and land into the bag. So that's the technique which we have published about 15 years back. Now, IOL power is an issue because the eye grows much rapidly in the first 6 months, and that's where the problem is. So if you see all the work up till now, I think people are following Hans and Prost for a long time. What we feel at RP Center is that the Inviadi's rule is a little more it suits better for the Indian eyes. So we did a study in which we found out that we have to do less undercorrection as compared to what they have said. So just see the top 3 columns. We took a patient, there were about 70 patients in each group, less than 6 months, 6 to 12 months, and 12 to 14 months. And this was the excellent and keratometry in this group. And the lens IOL power calculation and lens put was, these were the powers put in, and this was the undercorrection which we got in these patients. We use SRK2 formula. So we derived this formula from that, and that's what we've been using for a couple of years, and it's giving us very good results. So you just notice that 2 years of age, you have to go do only a 5% undercorrection, which is about not too much of undercorrection. Mild hyperopia is what you aim for. For 1 to 2 years, you need 10 to 12%. So a trick is to remember at 12 months, do 12% undercorrection. You will not be wrong by a big margin. 6 months to 1 year, it's a 15% undercorrection, whereas in Prost and the Hans, they were using 20% undercorrection for 1 year, which was too much of undercorrection, and they were everything is done on the table. You have to calculate, see the age of the patient, the time of the surgery, the intraocular pressures, and the sutures you're putting, and then you have to decide and take a shoot. So if you notice in this one now, if you are hitting a moving target, that means you're actually putting IOL in the eye, which is going to move, it's going to grow. So the less than 6 months will always have error. So you have to more undercorrection in these patients. So that's what is the formula we're following now. And our work has been published in the Indian Journal of Ophthalmology. And I think that's the last slide. So I'll take questions. Thank you.
So I won't take much time. So I would be discussing about the posterior optic capture in pediatric cataract surgery. After the wonderful presentation, what we've seen from Dr. Khoker, we'll have something different here. And I'd like to thank the Asia Pacific Academy of the Pediatric Ophthalmology Academy and Dr. Sumita for inviting me here. So our main aim in pediatric cataract surgery is always to prevent or minimize visual axis obscuration and inflammation. So that is what the goal is in pediatric cataract surgery. So there we use heparin, BSS, Experimentally, antimetabolites have been used to prevent visual axis obscuration. We have come out with improved technology in IOLs with square edges and acrylic material, which has helped us decrease this. Of course, the main thing which prevents it is primary posterior capsulotomy and anterior vitrectomy. And of course, when you do an IOL implantation in the back, that has been followed for over a number of years. So what is known as surgical techniques? The standard of care has been primary posterior capsulotomy. You do an anterior vitrectomy and an endocapsular IOL implantation, which was very well demonstrated by Dr. Coker. But there have been modifications and improvements, like we have some anecdotal reports on posterior optic capture, bag in the lens, which has been patented by Dr. Mary Jo, and of course, customization of the IOLs. Now, we don't have you can say the lens, which is patented in Europe. So what do we do now? So that's posterior optic capture, which was first advocated by Gimbel. Anterior vitrectomy was a step before capture. So these, in some of the series by Raina et al., who used a PMM IOL, he showed more inflammation than endocapsular implantation. One of the recent studies by Vasavada et al., again, they showed that there was comparable inflammation and visual axis obscuration when they performed no vitrectomy, but performed an optic capture. So why avoid touching the vitreous? The vitreous acts as a barrier between the anterior and posterior segment. In a growing child, we are not aware if disturbing it would have any consequences later in life. What is adequate, how much vitrectomy should be done in children is still not quantifiable, maybe subjective. Then we've seen in the previous video, how the vitreous behaves as a ghost, and you have strands of vitreous sometimes coming up when you do an anterior vitrectomy. An enlargement of a primary posterior capsulotomy may occur at the time of IOL implantation. So I just want to show you some of the cases which we've done where we performed optic capture, which means the optic is behind the posterior capsule, the haptics are in the bag, and we did not perform an anterior vitrectomy. So this is one of the videos here. We had a nice zonal cataract, and we performed an anterior capsular axis after staining it along the circumference of the cataract, of the central part of the cataract, and we got an appropriate size. And after that, removing the lens material, a primary posterior capsulotomy was performed. Now this has to be a larger one as compared to what we routinely perform, because we have to perform a optic capture, prolapse the optic behind the posterior capsule. So after inflating the bag with the viscoelastic, the intraocular lens must first go into the bag. So here we used a foldable 3-piece lens, hydrophilic acrylic, and we put it and implanted in the bag and then gently nudged one of the edges behind the posterior capsule. And this has to be very slow. We don't need a tear in the posterior capsule. The size is big, that's important. And the other thing is to gently nudge it behind. So we can see here an oblong posterior capsular axis, which shows that the IOL has been captured. So we have an IOL optic which is behind the posterior capsule and the haptics in the bag. Here we can see this is what we show. This is the oblong posterior capsule. So this was in a simple case of pediatric cataract. Coming to the complex cases, this is a patient with lenticonus. Now these are difficult cases. Again, the routine steps were performed by staining the capsule and anterior capsular axis of about 5.5 millimeters. And then after removing the lens matter, you can see here a bulge in the posterior capsule. So we chose to go along the circumference of this abnormal area so that we have a nice big capsular axis from where we can prolapse the optic of the IOL. So no vitrectomy was performed, and you can see here the IOL is being implanted in the bag, and now carefully just nudging it behind the posterior capsule, first one part and then the other part, and see, you can appreciate the oblong posterior capsular axis, which shows a captured intraocular lens. Now the third case is a persistent fetal vasculature. Now in this, what different did we perform? We performed the posterior capsulotomy using a cutter because it was very difficult to perform a capsular axis with the Utrata forceps. So I'll just be showing you. This is again, of course, the anterior capsular axis is same as we performed in any other case, even though it's larger, doesn't matter. So you can see here, you can see here the triangular wing-shaped extension, which is the persistent fetal vasculature, and the opacification of the posterior capsule. So this was very difficult. So that's why we used the cutter, and when we were using it, the stalk fell backwards. And after the IOL implantation in the bag, again, we're going to put it one half behind the posterior capsule and then the other half. So this is one edge going behind the posterior capsule. It's going to get oblong. And now we're going for the other half, just checking that it does not, the edge of the posterior capsule does not entangle in the edge of the IOL. So with a gentle nudge, you can see here again that you have an oblong posterior capsular axis without a vitrectomy and a nice anterior round capsular axis. So this is how we perform the anterior capsular axis. So coming to the next difficult case is the uveitis. So this is a child, a 5-year-old child with uveitis. And after releasing the synecdoche with the cannula, so I'll just go forward. So we're trying to release the synecdoche so that we have a fairly good area to operate, because we have to do a anterior capsular axis. And obviously in these cases, the inflammation, the post-op inflammation, the chances are fairly high. So we could achieve a fairly good pupillary opening. And after staining it, we had to be very careful while doing a posterior axis. Now this is a swollen lens. Just see how the fluid is going to come out. And the rexus was almost like, that's the fluid which is coming out. And the rexus was always just running to the periphery had we not stopped it. So we're just aspirating some of the fluid. So a swollen cataract in a uveitic eye, we had to be very slow and gentle with the capsule, because the morphology of the capsule would be different at maybe places it may be stuck somewhere, maybe fibrotic somewhere. So we had to have a really good capsular axis to have a good surgical outcome for this case. So after we've done this anterior capsular axis, which we could achieve with a strata forceps and removing the lens matter. So some of this was of course fibrotic, so the lens matter as such was a little, so we had to layer. So we have now a nice rexus, anterior rexus, and we gave another nick in the posterior capsule. So and raised a little flap of the posterior capsule before we fashioned a circumferential rexus, the size of which is almost equivalent to the size of the anterior rexus. So you can see here the posterior capsular axis, it's going to be almost the same size as the anterior capsular axis, because if it is not there, then there are chances that you won't be able to capture it, or it might tear it when you're trying to capture it. So once we've removed the posterior capsule, we inflate the bag with a viscoelastic and implant the IOL in the bag. So once the IOL is carefully implanted in the bag, the optics and the haptics in the bag, what we're going to do again is gently go to one edge, one half of the circumference of the IOL and take it behind the posterior capsule. And we have to gently caress it. Again, dialing is required here. You can't just push it there because it will tear the capsule. So you have to have a gentle dialing so that it locks at the optic-haptic junction. And similarly, the other part of the IOL has to go behind the posterior capsule. And there you see an oblong, you can see here an oblong posterior capsule axis, which shows that it has been captured. The optic is behind the posterior capsule and the haptics are in the bag. So this is some of the post-op photographs what we had. On the left side is an infant which we operated. This is the early post-op photograph showing an oblong posterior capsule and a nice anterior capsular axis. The fibrosis has started to happen. On the right side is a 4-year-old child, an early post-operative picture with a nice visual axis and a well-centered IOL. So this is an infant who's been operated at 10 months. On the left side, now it's the same eyes of the infant. This infant, the left is showing one, on the left is left eye, and probably on the right side, the right eye of the same child. So where we've done a capsular axis, a posterior capsular axis, anterior vitrectomy, and the IOL is in the back in this left eye. You can see here the floret epithelial cell proliferation occurring, where on the right side where we performed an optic capture without an anterior vitrectomy, the visual axis is shining clear, and all the proliferation is all sequestered in the bag. This is another patient. You can see here, this is on the left side is the picture where the IOL was implanted in the bag, and on the right side is the picture with the IOL implanted behind the posterior capsule, where you performed an optic capture without an anterior vitrectomy. You can see the difference in the lens epithelial cell proliferation. There is some synecdoche formation here on the left side, whereas the one with the capture is absolutely clear. So this is the last series of photographs. Of course, we published this. This is again left and right eye of the same patient. So you can see here, these are serial photographs. Now, on the left side, you have a follow-up at 3 months where you have a nice anterior rhexis and a posterior rhexis with anterior vitrectomy. The IOL is in the back. On the right side is the one with the optic capture. You can see here the fibrosis occurring, the sealing of the anterior and posterior capsule. If you see the 1 year follow-up, you have lens epithelial cell proliferation. Even though a good anterior vitrectomy, a good rhexis is done anterior and posterior, you still have anterior, you have proliferation. On the right side, everything is in the back. The visual axis is clear. And if you see a 2 year follow-up, again, you can see here some epithelial cells coming onto the anterior vitreous space. Whereas on the right side where you performed an optic capture, there is nothing. The visual axis is absolutely clear and everything is there between the capsules. So this is what we published here. We did a randomized study on these patients and showed fairly good results over a 2 year follow-up, which has been published in the Indian Journal of Ophthalmology. So I would like to conclude here by saying that optic capture is a promising alternative to conventional pediatric cataract surgery. We have shown the inflammatory response was less. The bag is sealed. So you have the anterior and posterior capsule, which is sealed. No visual axis obscuration or proliferation of the LEC can occur. There is no risk of geometric decentration because it's locked, the haptic-optic junction at the haptic-optic junction. It avoids the ill effects of vitrectomy. We still don't know the long-term issues of vitrectomy, what it could have. Yes, there's a learning curve, however, which can be mastered with time. Thank you all for a patient hearing, and I'd like to acknowledge my pediatric ophthalmology team here who've helped me with this presentation.
Thank you, Dr. Jaspreet. That was a very nice talk and an alternative to people who don't have access to good vitrectomy machine. I think it is very much replicable technique. And may I next ask Dr. Rajat Kapoor, who is a faculty pediatric ophthalmologist at LVPI Vizag campus, and he's going to talk about in children in whom sometimes there isn't enough capsular support. Rajat, can you go ahead, please? Your slides.
I hope I'm audible.
Yes, you are visible. Slides.
Yes, thank you. So without further ado, I'll just go ahead with the presentation. So the lens which I'm going to be discussing today is the iris claw lens. As we all know, this lens has been very well used, widely used, and also published in literature. The foldable variety, which is the artisan lens, very commonly used in European countries. However, the one which we are using is very cost effective. This is the retrofixated iris claw lens. It comes in two varieties with optic diameter of 3.5 and 5.5 millimeter. And I would like to show this small video, what instruments we use. So this is the forceps we use to hold the lens. As you see, the lower rim is more like a spatula, so it grasps the lens very easily. The lens haptics have a kind of a click or kind of a hole in between, and as you can see, the enclavation device can just pass through it. So this is just a brief. This is one of the study which we recently published, and this is comparing between the results of iris claw lens versus scleral fixated lens in ectopia lentis, and we had 36 eyes in the iris claw group, whereas 21 eyes in the scleral fixated group, and we had a reasonably long follow-up. These are the common indications which we have included in the study, includes Marfan's, microspherophakia, trauma, etc. And over the longest follow-up possible, we did not find any major difference between the visual acuity improvement in both the groups. There was almost a mean improvement of BCVA similar in both groups, and even the complication rates associated were almost similar. However, we felt that as compared to the SFIL group, the complication was slightly lesser. Anyways, so going into the technique, I will demonstrate a case. This is an 8-year-old female, microspherophakia, as you can see in both eyes. So I will just demonstrate the technique here. So this is the anteriorly subluxated lens, very soft jelly-like nucleus, and zonal subduct is very weak. And with a stab incision, I insert the vitrectomy probe straight into the heart of the nucleus and of the lens, and we start eating and aspirating using both IA feature and the vitrectomy feature. I'm using the Infinity platform here. And once we remove all the lens matter, we have to be very thorough. We can do a minimal anterior vitrectomy here. Now, we need approximately a mid-dilated pupil for using the iris claw lens, but sometimes you have situations where the iris is fibrotic and you don't really have adequate size, either it's too small or too big. You can use adrenaline, you can use pilocarpine to get adequate size. In this case, I'm just using a stretch kind of pupiloplasty. I'm using a clear corneal incision here because it's a microspherophakia. We might have some issues with the like syndromic features, some issues with the sclera. We can either use it through a clear corneal incision or through a scleral incision. I'm dialing the lens in place. I'm going to use one of the side ports previously created. At the bang opposite end, I will make another small side port. As you see, we just grasp the lens here with the inclination with the forceps, and one by one we'll tilt the lens and get the lens haptic just behind the iris tissue. Through the side port, in my right hand, I'm holding an inclination device, which is just like a dialer. It's a blunt tip dialer without any edges. And similarly, once it's stable, the lens stable on one side, we can do it on the other side. We can do a small PI as well using a vitrectomy. This is another case. This is a case of siblings of Marfan syndrome. As you can see, there is subluxated lens where the lens edge is bisecting the pupillary axis. I will just demonstrate. This is using the anterior chamber maintainer, grasping one edge of the lens using a pediatric rhexis forceps, and then again eating away the lens material with the vitrectomy. Some amount of zonular stress can be seen, which we can again take care of with the vitrectomy. And once we have removed the entire lens, so as you see that this is the adequate size which we need for the iris claw lens. If the size is too small, we end up kind of not getting a good shape after the surgery. So this is a really good size, ideal size for this kind of lens implantation. In a very dilated pupil, you'll always be scared that the lens might just fall down. However, in this size, we can stabilize it into the AC over the iris, and then one by one, we can tuck away the haptics into the iris tissue into the haptics. We can just tap on the optic haptic junction here and just make sure that the lens is stable before we insert the other half, so that we are very sure about it. So this is a post-op picture. You see there is mild ovalization, and similar case, different scenario. So this is a subluxated IOL. This is a scleral fixated IOL, which was done elsewhere about 3 years back. And in this case, we have to first explant the IOL. And as you can see, the haptic, the blue haptic you can see here, which is fixed in the sclera. So it took a little bit of pressure to kind of release it. And once that is done, we cut the lens. It's a foldable lens, so we can easily cut it using a scissors. And we'll cut the lens in the AC, and through a smaller opening, we can explant the lens. With this explantation also, it's helpful using this forceps. It's very easy to explant the lens, as you can see. And now the pupil here is a little distorted, and also the iris tissue is a little atrophic. In these kind of situations, there's no contraindication. You can still implant the lens. But the only thing is you will get a little bit ovalization more than usual because of the unhealthy iris tissue there. So as you can see, the lens goes one by one haptic tucking in. And once you have tucked in, you can of course see a small kind of dimple happening here, as you can see here. So you will get a small dimple which will tell you exactly how much, is the adequate iris inclination has happened or not. So yes, so this is the case completed. You can usually close with one suture or 3 sutures if it's clear corneal. And this is another like kind of a global developmental delay baby, and dense posterior synechiae, complicated fibrotic cataract. So after releasing the synechiae, we just use iris hooks to get some kind of mydriasis here to expose the lens. The anterior lens capsule is stained. It's very thick and rigid and not even able to penetrate with the capsular rhexis needle. So we use an MVR blade to kind of just penetrate and then eat the lens matter away with the vitrectomy probe, along with completing the posterior rhexis and the anterior vitrectomy. So this, since it's a developmental delay child, there's always a danger they might rub their eyes or hit their eyes hard. So I'm just using a scleral wound here. Similar kind of entry of the lens, and similar kind of process for enclaving the lens as well. So there are many indications where we can use this lens. The routine ones is like aphakia, secondary aphakia, children operated in young age, and later on presenting with aphakic. So when there is no capsular support or no rim, in those kind of situations, and syndromic lens disorders, and in post-trauma cases. And even this now lens is coming in 3.5 millimeter kind of variety, which we can even use in other indications, but still that role has to be explored. Thank you for your patient hearing, and I thank Dr. Sumita for inviting me to give this talk.
Thank you, Rajat, for finishing in on time, and hope to finish the session before we have the next time out. So once again, apologies for that technical goof up. But may I request Dr. Jason Yam to finish his talk, and then if we have time, we will take some questions. So Dr. Yam has been the chief architect for LAMP study, and let's see what he has to tell us about what we need to learn.
Sorry, thank you for the opportunity for me to share our study here. So I would like to share about myopia. I have no financial interest, and just to share with you some of our work is ongoing is the Hong Kong Children Eye Study, the LAMP study, the Hong Kong High Myopia Cohort, the Hong Kong Children Eye Biobank. Myopia is become very important, and because it is increasing in the prevalence, and in Chinese, 90% of the teenagers are myopia, and the potential complication of myopia, including macular degeneration, retinal detachment, cataract, and glaucoma. So it is a complex disease causing by both the genetics and also the environmental factors, including the increased education, decreased outdoor time, and increased near work. And the other are not very well consistent to be associated to myopia for the other factors. So in terms of myopia control, we have outdoor activity intervention, optical intervention, and the pharmacological intervention. So for the atropine eye drops, a lot of our work has been is learning from Taiwan colleagues who is using a lot of atropine eye drops in the whole region. And also a very important landmark studies from our Singapore colleague, the ATOM-1 and ATOM-2 study. In particular, the ATOM-2 study, we bring about the concept of using a very low concentration, 0.01%. In the good point of 0.01% is because the myopia rebound is very minimal. And in long term, over 5 years, according to the LAMP study, using 0.01% seems to be better than 0.1% and 0.5% in 5 years' time. And meta-analysis also suggested that the efficacy of atropine is dose independent within a very short low concentration, but the adverse effects are dose dependent. So, however, there are still some questions that remain to be answered. Number one, in the ATOM-2 study, there's lacking of placebo control group, and we don't know whether there's still a concentration dependent response and what is the optimal concentration. That's why we started our RCT, the LAMP study, to determine the optimal concentration of atropine eye drops. And it is an RCT of 438 children using placebo 0.01%, 0.025%, and 0.05%. We follow the similar follow-up protocol as of the ATOM-2 study for better comparison. And here's the result. It shows that here's the 0.05%, 0.025%, 0.01% placebo. In fact, there is quite a clear concentration-dependent response among all these concentrations. This is the SU length. And comparing to the placebo group, 0.05% confer about 67% in reducing myopia control, comparing to the placebo group, whereas 0.01% is about roughly 30%, 27%. And how about the side effect? The pupil size increase in 0.05% is about 1 millimeter. And the accommodation loss is about 2 diopter loss. 2 diopter loss is about 2 centimeter lengthening of your near point. So it is clinically not very significant. And also the use of photochromic glasses, progressive glasses, photophobia is all similar among all the groups. And we also administer the vision-related quality of life in all the groups, which remain similar among So this is the first RCT of low concentration atropine to demonstrate that low concentration atropine among 0.05%, 0.025%, and 0.01% compared to the placebo control group. And however, the axial length elongation between the 0.01% and the placebo group is not statistically significant. There is a concentration-related response, and all groups are well tolerated. In fact, our results are quite similar to our very recently published RCT using 0.01% in mainland China, 0.01% and placebo group. The result is also about in 0.01%, it reached about 30%, 34% reducing in the myopia progression. However, the question goes on because in the ATOM2 study, the effect is much better during the second year. Here you can see the mean change over 2 years only minus 0.5. Minus 0.5 diopter, but the over 1 year 0.43. So in the second year, the efficacy is much better than the first year, resulting in long term, the 0.01% is similar to 0.1 and 0.5% atropine. That's why we goes on to the second year report to see whether the second year efficacy is better. And here is in the second year, the placebo group, we switch over to the 0.05%. Because of the ethical issue. And here is the second year result. We found that the concentration dependent response still remain. Here is the 0.05%, 0.025%, and 0.01%. The switchover group, once you switch over, it remains very effective. And here we can see that the pupil size, accommodation amplitude remain largely similar to the first year. It didn't progressively worse. And the distant VA and the near VA all remain similar. And the concentration dependent response remain. And the side effect also remain largely similar comparing to the first year result. VFQ is also similar. Several points we want to make. First, 0.05% remain the most efficacious concentration over 2 years. And in fact, using 2 years, 0.05%, the effect is almost double than 0.01% over 2 years. And the efficacy in the second years remains largely similar, clinically similar to the first year in our LAMP study. And the switchover group 0.05% was effective comparing to the self-control. And all concentration remain well tolerated. We take the pupil size. Nowadays, people take 3 millimeter increase in pupil size as a cutoff. In the 0.05% is about 1 millimeter increase. And also accommodation change is only 2 diopter. And so the efficacy of 0.05% atropine observed was double than that of 0.01% atropine over 2 years. Another question goes on is we observed there's a discrepancy between the SE progression and the SE elongation in the ATOM2 study in 0.01% and also in the LAMP study. So people whether there is an effect of the atropine eye drops on the corneal curvature and the corneal power. That is important because whether atropine eye drops is reducing via the SU elongation is important rather than it is through other biometric changes because it is myopia complications comes from the excessive SU elongation. So in our lab study, we also look into the another report is look into the other anterior chamber, other biometric changes. We notice that here we can see this is the spherical equivalent. There's a concentration dependent response. This is SU length is also a concentration dependent response. But the change in the corneal power, change in the lens power, and the accommodation change are largely similar in all the groups. And we also notice the SU elongation, the SU length contribute to about 70 to 80% variation of the SE progression only. So therefore, we in our study we explain in fact the discrepancy between the SE progression and SU elongation because number one, the SU length contribute about 72 to 81% of the SE variance. And number two, because the children SU elongation include both the age normal growth and also the additional myopia associated growth. So it will not be completely parallel. Low concentration atropine has no effect on corneal power and lens power. The contribution to the SU progression are mainly from the SU length, but not the corneal power and the lens power. Its anti-myopia effect is reduced via the SU elongation. So in our third year report, we randomize each group into treatment continue group and also washout group. We want to look into the 0.05%, 0.025%, 0.01% over 3 years, and whether we should stop treatment after 2 years or whether we should continue the treatment, and the rebound phenomenon, which people are very interested to look into about the rebound. I hope we can share the result to you very soon. And I would like to thank our team, my mentor, Professor Kelvin Pang and Professor Clement Tam for the work together, and also my partner, Professor Chen Lei Gai, Dr. Gam Gawai, and Ms. Wendy for all the work together for all this study. Thank you very much for your attention. Thank you. I cannot hear, sorry.
No, I wanted to find out, what did you do for children who did not respond, non-responders to atropine? Did you do something for them?
Sorry, can you say again? Sorry.
No, non-responders, children who progressed despite atropine. Did you have any?
Now we now notice that we now understand that many non-responding is due to the age. The younger the age, the faster the progression, the more unrespond to all the treatment effects. So the younger the age, you need to use a higher concentration, whereas the older the age, you need to use a lower concentration. And of course, in Asia now, we also use combination therapy, combining the optical method, including the focus lens, and some people use OK lens to combine together. But there is no more solid results yet on all the combination therapy. We don't have the hard evidence yet. But combination therapy for fast progressor, I think should be the way forward. I cannot hear, sorry. Okay.
Which is the preferred concentration to start the therapy? The audience question has come.
So if it is the younger the children, you need to use higher concentration. So now my practice will start with 0.05% concentration for
young or for everyone.
Yes.
So thank you very much for answering these questions patiently, and thank you to all the speakers and all the attenders. I once again apologize for the technical glitches which marred the experience for everyone. And I hope in the next webinars, which will be hosted by APSPOS, will not have these problems associated. Thank you very much. Good evening.
Thank you, Dr. Sumita.
Any closing remarks, Dr. Jason?
So yes, indeed, it is a great pleasure to have this joint webinar. And thank you everyone for attending. And I hope this is a fruitful exchange of all our work and share of our ideas and also experience. Thank you very much, and have a nice day and good evening.
Thank you.
Thank you. Bye-bye.